Good morning, everyone. Welcome you all once again in Pedia Academy by Dr. Pankaj, myself, Dr. Pankaj. Today we are discussing part 3 of recall of NEET SS Pediatric. Some queries are there of students that some question stems are not exact. Yes, question stems might not be exact on recalls, but caution is nearby to those recalls. Purpose of doing this recall part 3 is or other parts is to actually get hold of that topic which is exactly asked in exam. Okay, so because this recall is not just mere collection of facts and other things, we have discussed detailed topics in separate lectures. You can scroll through in this YouTube playlist also. And many questions are from our question bank, which is NEET SS Pediatric question bank, which was conducted test series. And one small announcement before starting our this discussion. We'll start a comprehensive Nelson-based lecture series for upcoming NEET SS Pediatrics and pediatric residency program students also. Without further delay, let's start our part 3 of this recall session. Okay, so question number 62. A child on CVS examination is found to have normal splitting of second heart sound. Which of the following cardiac lesion is least likely? Okay, so this is simple, straightforward question from the cardiology, pediatric cardiology. Okay, what is this? Just wait. Okay, which of the following cardiac lesions is least likely? Options are VSD, ASD, TOV, and patent ductus arteriosus. Somehow all pediatricians know arterial septal defect presents with split S split S2. Okay, so this was the question and answer, but our aim here to dissect these actually important cardiac lesions. Okay, now see compare ASD, VSD, PD and AV canals. Okay, so these are defect, these are important for exam. So what we'll see, we will read vertical. So that's how vertical reading will actually for comparison. And if you want to know nutshell about that disease, you should go in this direction. Okay, first we will go vertical. We will talk about ASD frequency. Okay, so this is 7%. VSD is commonest. So you have to remember in this vertical arrow is VSD is commonest. Gender. Okay, female to male ratio in ASD is 3:1. VSD it is controversial. PDA is female to male ratio is 2:1. And AV canal it is equal. Okay, so this you have to remember. Pathognomic sign as we discussed, fixed split as 2. So this should be split and fixed. VST it is holosystolic murmur with thrill left lower sternal border. PDA it is continuous machinery murmur. AV canal defect left axis deviation very much important. Minus 92 minus 180 with fixed split S2. Here we found differential diagnosis of fixed split S2 is AV canal and ASD. The difference in left axis deviation, right axis deviation. Okay, so murmur location, this is also important. Left upper sternal border in ASD, left lower sternal border in VSD, left upper sternal border plus left clavicle in PDA, and left lower sternal border plus apex in AV canal. Okay, volume overload. Just remember this table is very much important because it gives this is crux of what we are reading and teaching. AST it is right atrium and right ventricular volume overload. In VST it is left ventricular right ventricular enlargement. PDA it is left ventricular plus left atrium enlargement, and AV canal all four chambers are enlarged. ECG, again, this is very much important. RSR1 pattern in V1 plus a right axis deviation is seen in ASD. RSR pattern is also seen in AV canal defect but left axis deviation. So, AV canal defect and ASD can be differentiated by axis deviation, and axis deviation is the main thing because left axis deviation is seen in AV canal defect and the right axis deviation is seen in ASD. Otherwise, in both in ASD and AV canal defect, fixed split second heart sound is seen and RSR1 pattern is seen in ECG in both the conditions. Okay. CHF in infancy, it is rare, yes, in ASD. It is common in VSD at 4 to 8 week. You have to remember this. Spontaneous closure rate, very much important. If your ASD is less than 5 millimeter, 30 to 50% chances to be for closure. In VSD, muscular closes earlier than membranous, very much important. Overall, spontaneous closure rate is 30 to 80%, very much important. Okay, AV canal never actually closes spontaneously, so correction is required. Device closure. In all three conditions, ASD, VSD, and PDA, you can close the defect from device, but not in AV canal defect. So, AV canal defect doesn't actually closes spontaneously, and surgery is required. No device closure is successful. Eisenmenger syndrome is actually high in VSD risk, and in AV canal defect, yes, if AV canal defect is associated with Down syndrome, which is most common association also, so this is high in first year of life. So just see what we have discussed. We have discussed caution, and we actually not left the caution there only. We have discussed these clinical salient features of this disease, of this congenital heart disease. So this is very important. At least 7 to 10 potential MCQs are hidden in this table. So if you want to read individual disorders, you can read like this. Okay, and if you want to compare these table, you can go like this. Okay, so on this note, we are going to our next question. Question number 63. So, a child presents with growth failure, polyuria, metabolic acidosis, glycosuria with normal blood glucose and amino aciduria, suggestive Fanconi syndrome. Okay, so this was Fanconi syndrome clearly. Okay, the child is found to have hepatic involvement and neuropsychiatric symptoms. So, what should be the diagnosis? Okay, some students say, sir, this was caution stem was of oculocerebrorenal syndrome, Lowe syndrome. So, Lowe syndrome was the answer. Anything is there, but crux of my teaching is that you should go for caution stamp. Okay, this caution stamp is might be different from original caution stamp, but crux will remain same. By this description and neuropsychiatric manifestation, hepatic involvement, our answer is disease Wilson disease with Fanconi syndrome. If oculocerebral renal syndrome scenario is there, you have to mark that also. So again, what I'll do, I'll put some light on this congenital dyserythropoietic anemias because they're frequently tested. So what I'll discuss is Fanconi anemia, dyskeratosis congenita. There was a caution on this also. So Ashman-Diamond syndrome. Again, one question was on this syndrome also. And congenital amegakaryocytic thrombocytopenia has kept for comparison. So similar pattern we will follow. If you want to compare, read like this, and if you want to read individual disease entity, read like this. Okay, first we will go to inheritance pattern. Okay, so inheritance pattern in Fanconi anemia, they are most commonly autosomal recessive. Some are X-linked recessive, which one? FANCB1. So you have to remember that. Dyskeratosis congenita are X-linked recessive, in DKC1 gene, but in if gene is TINF2, TERC, TERT, they are autosomal dominant also. So just remember, in this keratosis congenita, every possibility of inheritance is possible, but generally they are X-linked recessive, and the most common gene is DKC1. Swashman-Diamond syndrome, these are autosomal recessive. Genes are SBDS, DNAJC21, you have to remember. And congenital amegakaryocytic thrombocytopenia, these are autosomal recessive. Pathognomic triad, this is very much important. Okay, in Fanconi anemia, capillute spots are there, thumb or radius anomaly will be there, short stature will be there. Means child will be short, thumb or radial anomaly will be there, and capillute spot will be there. This keratosis congenita, this is nail dystrophy plus lacy pigmentation plus oral leukoplakia. Okay, these are pathognomic triad in exam. They can ask you image of this nail dystrophy and lacy pigmentation and oral leukoplakia. So this pathognomic triad is very much important. Coming forward to which was your exam question also, Sheshman-Draiman syndrome comprise of exocrine pancreatic insufficiency plus neutropenia. Very, very much important. This is repeat NEET SS question. Just remember this thing. These keywords are important in skeletal dysplasia. Okay. Congenital amegakaryocytic thrombocytopenia. As name suggests, it is thrombocytopenia uh, plus absent megakaryocytes. They are normal at birth. Okay, so it is age representation, which is also important. So median age of this bone marrow failure is 7 years in Fanconi anemia. Okay, in this keratosis congenita, mucocutaneous in first decade and bone marrow failure in first or second decade. Very much important. Okay, Schwarzman-Diamond syndrome, they present since birth. Steatorrhea is the presenting symptom. CMT patients present with thrombocytopenia as prominent feature, and they are actually symptomatic from infancy. So, what is diagnostic test? Again, very important. Chromosomal breakage is increased with MMC and DEB. These are two drugs. If they are put in blood of the Fanconi anemia affected patients, there will be more chromosomal breakage. Breakage, sorry. So, in this keratosis congenita, very short telomeres, less than 1 percentile. Again, this is caution. Okay, Schwarzman-Diamond syndrome, low serum trypsinogen plus isoamylase. This is also separate question. So this is congested looking table, but I have compiled all things together so you can solve at least 10 potential MCQs from this table. Megakaryocytes and MPL mutations is seen in CMT. What are hematological pattern? In Fanconi anemia, it is macrocytosis with thrombocytopenia leading to pancytopenia. Basically, it is pancytopenia, but the sequence is macrocytosis, thrombocytopenia, and pancytopenia. In dyskeratosis congenita, first thrombocytopenia, then anemia, then pancytopenia. So, pancytopenia occur in 80% by age of 30. Okay. Schwarzman-Diamond syndrome, on the other hand, neutropenia is initial presentation in seen in 90% and pancytopenia seen in 21 to 44%. This is also important. And we know CMT leading to isolated thrombocytopenia, pancytopenia develops later. What is cancer risk? Again, very much important. Squamous cell carcinoma of head or neck is having 600% risk, which is very much significant. AML and MDS having 33% risk by age of 40. Okay, similar pattern seen with dyskeratosis congenita, and in Schwarzman-Diamond syndrome, it is AML MDS is 25% by age 18. Okay, so this is also important. Treatment is actually detailed. I'll discuss some salient point of this. For Fanconi anemia, You have to give hematopoietic cell stem cell transplantation. This should be fludarabine based and low dose. Okay, so HSCT is also used for dyskeratosis congenita, and this is also used for Schwarzman-Diamond syndrome. HSCT is curative in CAMT. So again, just pause this video here. Go through this table once again. This is having crux of all phenylketonuria, dyskeratosis congenita, Schwarzman-Diamond syndrome, and CAMT. At least I earlier also discussed 7 to 8 or at least 10 MCQs are expected out of it. Going forward to next question. Question 64. A child in septic shock remains hypotensive after 60 ml per kg of fluid. The next step should be, okay, so they have given septic shock clinical vignette. I have just written septic shock here, but they have given a child presented with emergency with fever and blood culture was positive. So it was clinical vignette of septic shock. They said they gave 20 of ml per kg NS up to 60 ml per kg, and child is not responsive. What is the next step? Okay, so basically they are asking this surviving sepsis guidelines. Okay, so they are saying, so just go through this. If after 3 bolus, okay, what they are saying, just if septic shock is there, just uh, give your attention here. If septic shock is there and abnormal perfusion is there without hypotension, in our case it is hypotension, but see if the without hypotension is there, so we have to give bolus and epinephrine if myocardial dysfunction, and non-epinephrine if shock persists after 60 ml per kg. Okay, so the vasopressor of choice is noradrenaline if bolus, even after bolus it is shock persist. Same for abnormal perfusion with hypotension. First you have to give bolus and consider epinephrine oblique non-epinephrine for this. Again, very much important. Okay, so after that, what you have to see, systolic BP if it is less than 50 millimeter of mercury in children less than 12 months. Okay, or systolic BP is less than 70 in children more than 5 years, or systolic BP is 60 millimeter in children age 1 to 5 years. Presence of all three World Health Organization criteria, cold extremity, and prolonged capillary field more than 3 second weak pulse. So this surviving sepsis guideline you have to remember, this is important. Okay, so our answer should remain this start nor add. Okay, so nor add will be our start answer. Okay, coming forward to next question, question number 66. A child with known congenital heart disease is planned for dental extraction. That's fine. Which of the following is most appropriate approach regarding infective endocarditis prophylaxis? So they are very fond of asking infective endocarditis. So what are the options? Oral antibiotics should be prescribed before procedure. IV antibiotic before procedure. No antibiotic required, and no antibiotic but closed procedural follow-up is required. Answer of this question, the stem might be different in original exam, but from the stem of question, answer should be no antibiotic prophylaxis is required. Okay, why? You just see 2023 European recommendation of antibiotic prophylaxis in patient with cardiovascular disease undergoing orodental procedures. Okay, so in which condition it is required? So just remember, in these conditions it is required. Apart from any condition, prophylaxis is not required. So this table is required prophylaxis. So what is prophylaxis? Previous infective endocarditis, you have to give prophylaxis. Okay, surgically implanted prosthetic valve, Yes, you have to give prophylaxis. Okay. Transcatheter implanted aortic and pulmonary valvular prosthesis you will be requiring. Okay. Transcatheter mitral tricuspid valve repair you will be requiring prophylaxis. Okay. In untreated congenital heart disease, cyanotic congenital heart disease, surgery, shunt, conduct, okay, you have to do this. Even after surgical repair, in absence of residual defects or wall prosthesis, antibiotic prophylaxis is recommended for first 6 months after the procedure. Okay, this was INISS question. Stem was like that. A patient was repaired surgically. There is no residual defect, no wall prosthesis. How long you will give secondary prophylaxis? You will recommend secondary prophylaxis in for 6 months after that cardiac procedure. So again, this table is ultra important. Mark it as your last day copy, or you need to remember it. Okay. Next question. Question number 67. Okay, so this is question number 67. A term neonate, 2 days old, present with cold periphery, respiratory distress, and shock. Okay. The diagnosis of duct-dependent congenital lesion is suspected. Okay, as clinical vigilance is pointing towards this also. Prostaglandin E1, PGE1 infusion started, following which baby shows initial improvement. Okay, however, somehow PGE1 infusion is suddenly stopped, after which neonate deteriorates rapidly with worsening shock. So this shows the lesion was duct dependent. Okay, in exam, just read the question stem very carefully, because sometimes answer are hidden in this. So they are saying they started prostaglandin E1 infusion after stopping suddenly, patient condition worsened, means, so this, the options are there, but answer in your mind should be you have to restart PGE1 infusion, because this is duct dependent circulation. Okay, so what are the duct dependent circulation? Because they are depending on ductus arteriosus flow. So some are duct dependent pulmonary circulation. So what is those? Severe TOF, pulmonary atresia with intact ventricular septum. Remember, they ask in exam. So at least one question is expected if they ask about prostaglandin or duct dependent lesions. Cortical pulmonary stenosis, severe Epstein anomaly, single ventricular pulmonary stenosis and atresia. Okay, what are the ductal dependent systemic blood flow? They are hypoplastic left heart syndrome, critical aortic stenosis, critical aortic coaction, interrupted aortic arch, single ventricular aortic stenosis and atresia. You have to remember this. And inadequate mixing, DTG of great transposition of great arteries is also there. So these are prostaglandin dependent, or duct dependent, sorry, duct dependent pulmonary systemic circulation. Okay, going forward to next question, question number 68. Okay, a child present with acute upper GI bleeding, swine, hematemesis, and or melena. Okay, after initial stabilization, which is the following the most appropriate next step in management? Options are transfuse red blood cells to maintain hemoglobin 10, insertion of Sengstack Blackmore tube as first line therapy, perform angiography of celiac axis superior mesenteric arteriosplenic vein to localize the bleeding site, upper GI endoscopy. So what they are saying, bleeding was there and initial stabilization was done. Okay, bleeding was there, initial stabilization was done. So we will see answer of this question is upper GI endoscopy. But why upper GI endoscopy? For that we will see important concept. Okay, so upper GI endoscopy is the investigation and treatment of choice in acute huge upper GI bleed once patient is stabilized. So if patient is stable, go for endoscopy. PRBC, that is important. Blood transfusion you have to use judiciously. Your target should be 7 to 9 gram per deciliter, not more than 10. Routinely, you don't actually exceed 10, but it's 7 to 9. Sangestin Blackmore tube, I hope you have heard about this. This is reserved for refractory variceal bleeding. It is not the first line drug. First line procedure, sorry. Angiography is used when endoscopy fails, so bleeding source is not identified. So in our this question, answer should be clear cut upper GI endoscopy. Okay. So next question. The first line treatment of systemic onset juvenile idiopathic arthritis. So options were methotrexate, NSAIDs, corticosteroids, sulfasalazine. Okay, so this is some pitfall questions, or you can say trap questions. Everybody will say we will start with NSAIDs, but answer is wrong because they are asking about SOGIA, systemic onset juvenile arthritis. So what Nelson says exactly, okay, so I'll quote Nelson here. They say management of GIA include and many management guidelines with actually ophthalmological evaluation to other evaluation, and optimal treatment is ophthalmologist and rheumatologist management is there because the collaboration is required. So, but what happens in SOGIA, systemic onset JIA, in this, just see, yeah, in SOGIA, what happened? Yeah, just there. Okay, so so this answer of this question in SOGIA, there is actually corticosteroids are required. So this is first line management of systemic onset juvenile idiopathic arthritis. Question number 70. Okay, so this might be of a different question or STEM in examination, but here they are asking a child present with high grade intermittent fever for several weeks associated with arthralgia, arthritis, and evanescent salmon color rash. Systemic features suggestive of lymphadenopathy and hepatosplenomegaly. There is no evidence of infection or malignancy. What should be the diagnosis? GIA, systemic onset GIA, enthesitis, related GIA, polyarticular juvenile idiopathic arthritis. So what should be the answer? Answer should be systemic JIA. So this is very important table from Nelson Textbook of Pediatrics. What you have to see the definition. This is short question in exam. So just go through with this. So what they say, arthritis in one or more joint with preceded by fever of more than 2 week duration. Okay, arthritis is there with fever is more than 2 week duration. Fever should be daily for at least 3 days. Okay, so they are saying fever, total duration of fever will be more than 2 weeks, 14 days. It should be more than 14 days, but continuous fever or daily fever should be noted at least for 3 days and accompanied by one or more of the following. Which of the following? One or more. Okay. So what is there? First, rash. So envasant non-fixed erythromatous rash, generalized lymph node enlargement, okay, hepatomegaly or splenomegaly or both, and serositis. So you have to remember rash, generalized lymph node enlargement, hepatomegaly, splenomegaly both, and serositis. If these things are there, you will mark this patient as systemic GIE. Just remember this is very important. Oligoarthritis affecting 1 to 4 joint in first 6 month category. So for 6 months they are affecting 1 to 4 joint. So it has been divided into persistent oligoarthritis and extended oligoarthritis. In extended 5 or more joint affected after first 6 months of disease. Polyarthritis RF negative. So, polyarthritis as compared to oligoarthritis, they affect 5 or more joints during first 6 months of disease. RF is negative. Polyarthritis which is RF positive. So, RF is positive, but RF positive criteria has been asked. They are saying two or more tests for rheumatoid factor at least 3 months apart during first 6 months are positive. Okay, psoriatic arthritis, they are saying arthritis and psoriasis. If there, then it is psoriatic arthritis, but arthritis and feature suggestive psoriasis more than two, that is dactylitis, nail pitting, and psoriasis is first degree relative, it is psoriatic arthritis. Enthesitis related arthritis, arthritis plus enthesitis or enthesitis with at least two of the following. They are saying sacroiliac joint tenderness history, HLA-B27 positivity, arthritis in a male more than 6 year old, a acute symptomatic anterior uveitis, history of ankylosing spondylitis, enthesitis related arthritis, IBD, Ritter syndrome, etc. So at least two are required. Undifferentiated is different. Okay, so some definitions are here in footnotes also. Quotidian fever, daily fever, they are saying that fever that rises from 102.2 degree Fahrenheit once daily and return to baseline between fever peaks. Very much important. So just pause this video here, go through this important table once again because many questions are expected from this table. Okay, they will ask definition, criterias of definition of systemic GIE, oligoarthritis, polyarthritis, RF positivity. They'll ask two tests 3 months apart. Psoriatic arthritis, there's more than two features, enthesitic related arthritis, etc. So just go through this. This is very much important. Okay. Okay, so next is question number 71. Which of the following features best differentiate primary, that is familial HLH from secondary HLH? So HLH is important entity. Generally, it is asked in exam in various presentation. In this question, they are asking uh, HLH differentiation from primary to secondary. Okay, options are ESR level, serum ferritin, NK cell activity, and CRP. Okay, so answer of this question is NK cell activity. Okay, I'll explain why it is NK cell activity. This NK cell activity. So what happened? Reduced or absent NK cell activity is hallmark primary HLH. Very much important. Okay, other markers are same in primary and secondary HLH, but this is the differentiating factor. Okay, going forward to next question, question number 72. A child has been immunized as per schedule till 14 week of age, okay, but did not receive rotavirus vaccine. Fair enough. Parents now present when child is 6 months old and request rotavirus vaccination. What is the most appropriate advice according to Indian Academy of Pediatrics guideline you will give? Okay, options are this question stand again might be different from regular question, but options are like this. Option A, administer rotavirus vaccine now and complete the schedule before 1 year of age. Second, option B, rotavirus vaccine can be given at any age in infancy. Start rotavirus vaccination before 1 year of age or do not administer rotavirus vaccine as per schedule. Answer of this question is D. Why D? Just see. So, IAP guidelines for rotavirus says the first dose of rotavirus vaccine must be given before 15 week of age. This is important, and all doses, this is first, and all doses must be completed by 8 month, that is 32 week of age. Basically, you have to remember 15 week and 32 week. Okay, so 15 week is the cutoff for first dose of rotavirus vaccine, and 32-week is all doses must be completed by. So in this scenario, you have to refuse the child. Why this guidelines are there? Because increased risk of into susception with late initiation is there. So that's why this 15-week and 32-week recommendations are there. Going forward to next question. Question number 73. Okay. Exclusively breastfed infant receiving additional bovine milk supplementation presents with blood streak stool and rectal ulcer. Okay, noted on evaluation. Infant is otherwise thriving and systemic examination is normal. So you have to see keyword in this question. Keywords are bovine milk, blood streak stool, and rectal ulcer. Okay, somehow this presentation, basically this is again clinical beginner type of question. In these questions you have to first think then of diagnosis, then you can think of treatment. So in this condition the diagnosis is cow milk protein allergy. So in this condition you have to stop cow milk in mother's diet and also baby's diet. Okay, so both mother and baby cow milk intake should be stopped. Okay, so so this is food protein induced allergic proctocolitis. FPIAP is the short form, and it is due to cow milk protein allergy. Okay, so this cow milk passes into breast milk if mother consumes cow milk. That is very much important, and you have to exclude cow milk from both baby and mother diet. Okay. Next question is, a child with first episode of idiopathic nephrotic syndrome was treated with prednisolone for 12 weeks, 6-week daily and 6-week alternate, and achieved remission. So remission was achieved. Child relapses within 14 days of stopping steroid. So what it will be caused? So this is frequent relapsing, steroid dependent, or start with calcium inhibitor. This is steroid dependent nephrotic syndrome. Okay, exact question in exam might be different, but crux of these questions are same. They are testing your important definitions. So just see, nephrotic syndrome definition I'll discuss: proteinuria, hypoalbuminemia, and edema. So this is triad. Clinical threshold is protein is 3 to 4 plus, albumin is less than 3 gram per deciliter, and urine protein to weight ratio is more than 2. Okay, so cholesterol is not mandatory for diagnosis. That is also important. Remission, what is a remission? Protein nil or trace for consecutive 3 days, and urine protein and urine create ratio is less than 0.2 milligram per milligram. Okay, this is remission. Relapse, protein is more than 3 for 3 days. This is remission. Frequent relapses, new definition you have to remember: 3 relapses in any 6 months. Okay, older definition was more than 2 in first six months or more than 4 in a year. So this is new definition, you have to remember this. This is very much important. Steroid dependence, 2 consecutive relapses on alternate day steroids or within 14 days of stopping steroid. This is called steroid dependence. Again, very much important. Steroid resistance, basically there is no remission despite 6-week daily prednisolone, 2 milligram per kg. It is not 4 week. These are the latest guidelines for nephrotic syndrome. Complicated relapse, all we know, any complication occur, this is complicated relapse. So just pause your video here and just revise these important definition, because any question can come from these. Okay, so going forward to next question, question number 75. This is a child with macroorchidism, intellectual disability, and long face is likely to have Klinefelter syndrome, Fragile X syndrome, Prader-Willi, Angelman. Answer is Fragile X syndrome. So, in this, just remember, uh, main symptoms are very much evident. facial features of this Fragile X syndrome is long, narrow face, prominent forehead and jaw, large ear, flat feet, enlarged testicles. This is called macroorchidism, low muscle tone, developmental delay, and intellectual disability and seizures. So basically, two large things are there: large ear and large testis. That's how you can remember this Fragile X syndrome. Okay, going for to next question. If fetus was diagnosed antenatally with left ventricular outflow tract obstruction, is found to have cardiac rhabdomyoma on fetal echocardiography. That is very important finding. The fetus has progressive obstruction but no hydrops. What is the most appropriate option of management is option A, option A, immediate in utero surgical excision of tumor. Option B, intracardiac or intraamniotic drug injection to reduce tumor size. Option C, maternal treatment of mTOR inhibitor. And option D is termination of pregnancy. So basically they are asking about cardiac rhabdomyoma management in antenatal women. So answer of this question is C, maternal treatment with mTOR inhibitors. So just see about we will discuss this in detail. So cardiac rhabdomyoma, they are associated strongly with tuberous sclerosis complex. Okay, these cardiac rhabdomyoma often cause left ventricular or right ventricular outflow tract obstruction. They regress spontaneously postnatally, very much important. They are mTOR pathway driven. So mTOR pathway is there. That's why mTOR inhibitors like everolimus or sirolimus is required for these. So these mTOR inhibitors can be given to mother because they crosses placenta and leads to significant reduction in fetal abdominal size, improved improve obstruction without surgery. So this question is very important. Just see maternal treatment is mTOR inhibitors for rhabdomyoma. Okay. Next question is question number 77. Question stem actually might be different, but crux will be same again as we discussed. A newborn presented with severe growth retardation, microcephaly, wide nasal bridge with Greek warrior helmet. Some students are saying this term was not there in exam, but okay, if it is not there, no issue. Seizures, developmental delay, congenital heart disease. So this is again clinical weakness type of question. In exam, they generally ask these type of questions. Okay. So which chromosomal abnormality is most likely present in this condition? Options are deletion of 5p, 7q, 4p, and 11q. So this is confusing if you are less read. Answer of this question is deletion of 4p. Okay, so we'll discuss this deletion of 4p again with this help of this picture. So this is deletion of 4p is caused, it is Wolf Hirschhorn syndrome. What are the main facial features? Large wide spaced eye, ear abnormalities, high forehead, broad nasal bridge, small chin and head, and cleft lip and cleft palate. Okay, along with this, these features like Greek warrior helmet, like severe growth retardation, microcephaly, developmental delay, these are most common finding. So this was about Wolf-Rayet syndrome, deletion of 4p. Okay, coming back to next question, that is question number 78. A woman with previous child affected by neural tube defect should receive which preventive therapy next pregnancy? Basically, the they are saying the her child was affected and second child is about to born, so or she is pregnant. So folic acid dose 0.4 mg, 1 mg, 4 mg, B12 supplementation. Answer is high dose folic acid because previous child was affected with this neural tube defect, so she should receive preventive therapy in next pregnancy, very much important. Okay, so these are neural tube defects. Just go through once: anencephaly, cariosiasis, open spinal bifida, colon. This is closed spinal bifida, encephalocele, anencephaly. Okay, so these are things of under heading of this neural tube defect. We have discussed them in separate lecture. Please go through these lectures. These are there available in YouTube. Okay. I'll discuss them in very detail in our next upcoming course. So stay tuned for that. Okay. So question number 79. Just see the key principle in management of hypernatremic dehydration. Option A, should we do rapid sodium correction? No, rapid sodium correction is not recommended. Free water bolus? No. Hypertonic sign only? No. And sodium correction 10 to 12 milligrams per liter per day? Yes. It should be below than this, less than this, less than. Because otherwise, if you cross this limit, there is a risk of cerebral edema. Okay, so I'll just see. I have given and I made an algorithm of hypo hypernatremia. Okay, so normal serum sodium is 135 to 145. Okay, if hypernatremia is there, just see with hypernatremia, if weight loss is there, means dehydration is there. Okay, so fluid correction over 48 hours you will give, because once you correct dehydration or weight loss, basically weight loss will be corrected and hypernatremia will be get correct. Okay, but hypernatremia associated with weight gain. This is salt plus water overload. This is fluid plus sodium restriction. Both you have to do. Okay, just remember. If we are on other hand seeing hyponatremia with the weight loss, means sodium loss is there, then you have to replace sodium. And hyponatremia with weight gain, it is suggestive of water excess, fluid restriction is required. Okay, acceptable urine output is 1 to 3 ml per kg per hour. Specific gravity is 1.0052 to 1.012 and osmolality is 100 to 400 ml per liter. Basically, this is simple looking flowchart, but it contains many critical questions in your upcoming exam. Going forward to next question, question number 80. A child with polyuria with polydipsia has urine osmolality 132 milliosmol per kg after water deprivation, no response to DAPPV. So this is classical description of nephrogenic diabetic insipidus. Okay, they were asking stored by students partial and complete. So if question stem will contain certain information for those questions, otherwise if this question was asked like this, answer of this question is nephrogenic diabetic insipidus. Okay, going forward to next question. This question says, question number 81, a 3-year-old child presents with recurrent ear discharge, okay, failure to thrive, and scalp swelling. Examination reveals seborrheic dermatitis like skin lesions, and skull radiograph shows multiple well-defined punched out lytic lesions. So till now, you have must have understood what is question stain is looks like. So they are saying Langerhans cell osteocytosis is suspected. They are giving you a diagnosis. What they are asking, ISC finding, so CD3 positivity or IHC, is it so? Second, second is bone marrow biopsy showing histocytic proliferation. Option C is CD8 positivity on biopsy and CD20 positivity. If this is clinical vignette suggestive of LCH, answer should be this is CD1A positivity on lesional biopsy. So just see this actually this disease condition in this jaw is affected. Okay, and this histology picture is there, mouth picture is there. So this is Langerhans cell osteocytosis. Coming on to question number 82. A child with laboratory confirmed dengue fever presents on day 4 of illness. That's fine. There is no warning sign. He is hemodynamically stable, feeds well, and normal urine output. However, serial investigation shows rise in hematocrit by 10% of baseline. Platelet count is low, but there is no bleeding. What is the next appropriate management? So, in this question, just go through this flow chart. Okay. So, this flow chart say if your dengue infection is asymptomatic, no need to do anything. But if it is symptomatic, if it is mild, fever of 2 to 7 days with any of following nausea, vomiting, rash, headache, intolerable pain, myalgia, arthralgia. So group A, you have to do outpatient management. Okay, if your symptoms are severe, so this patient has to go for group 3 inpatient ICU management. But if your patient is symptomatic and moderate intensity of disease is there. So just see dengue with warning sign and symptoms and dengue with high risk comorbid conditions. This is inpatient management group B. So just see our options and question. The right answer must be send the child at home with strict advice regarding danger sign and follow up. Again, I'm reminding you all this recall is exact recalls of topics and nearly simulating questions are there. So stem might be different. Just think of the stem of the question and we are giving questions accordingly along with we are explaining you is very detailed overview of that question. Okay, so going forward to next question, question number 83. A 6-year-old child presents with progressive increasing pain over right thigh over past few weeks. That's fine. It is localized tenderness. X-ray of femur suggestive of diaphyseal lesion with characteristic onion peel periosteal reaction. Base of this, most likely diagnosis is suggested by these condition, which is the genetic abnormality. So again, I explained you all before also, clinical wicked type questions are available mostly because they test your clinical uh, skills. Okay, so just see options are RB1 mutation, and MYC gene amplification, translocation 1122, and TP53 mutation. If you have analyzed that this is Ewing sarcoma, your answer should be this. Okay, so just see osteosarcoma, Ewing sarcoma. I'll just discuss difference between two only. So osteosarcoma is primary most common bone malignancy. Ewing sarcoma is second most common bone malignancy. Okay, both osteosarcoma and Ewing sarcoma occur in second decade. Okay, what is the location that is important? Location of osteosarcoma is metaphysis of long bones, but the location of Ewing sarcoma is diaphysis of long bone and flat bone. Pathological sign is sunburst or Codman triangle in osteosarcoma and onion skin moth-eating appearance in Ewing sarcoma. Okay, so histology, small round blue cells with CD99 positivity is suggestive of Ewing sarcoma. Okay, translocation, just see for Ewing sarcoma, it is translocation 1122 EWS FL1, very much important. Okay, systemic is not that important. What is the first line treatment? So osteosarcoma, it is chemotherapy. It is Ewing sarcoma, it is also chemotherapy. Okay, so this is about osteosarcoma, Ewing sarcoma. Just see salient points of rhabdomyosarcoma. This is because we are discussing as a whole holistic discussion. So this should be there. So rhabdomyosarcoma is most common soft tissue sarcoma, 3.5% of all cancers, very much important. Okay, Pathognomic sign is sarcoma moderates, vaginal grape-like mass. Okay, this is Fox O1 or tax 3, 80% is alveolar type. Okay, on the other hand, synovial sarcoma is most common non-rhabdo tissue, soft tissue tumor. Again, very much important. Extremity, lower extremities are more involved than upper extremities. So you have to go through this table once again. It contains many questions out there. Okay. Next question is question number 84. In this question, they are saying a child presents the characteristic facial features, including an inverted upper lip, okay, that's fine, high arched palate, an elongated narrow face. There is history of developmental delay, and the mother has difficulty releasing her grip and handshake. So, genetic testing is suggestive of which type of trinucleotide repeats. So, just see clinical vignette. They want to say something, and they are asking of trinucleotide repeat. So, by the description of in caution stem, this looks myotonic dystrophy. And for myotonic dystrophy, answer is CTG repeat. So once you analyze the clinical vignette question in your exam, your answer will be easy, like we did in this. So this is CTG. Okay, so some trinucleotide repeat disorders are there. You need to remember this is ultra important table because they ask in exam, and this is for last day revision, otherwise you forget it. So very important. Huntington is CAG, myotonic dystrophy is CTG, spinobulbar muscular atrophy it is X-linked, spinocerebellar ataxia it is CTG, Friedreich ataxia is GAA, Fragile X syndrome CGG, and Howe River syndrome is CAG. So again, these trinucleotide repeat disorders are important. Just go through these table once. Question number 87, next question. A child with known case of NF1 presents with progressive visual impairment. You did neuroimaging and found optic pathway glioma involving in optic chiasma, evidence of compression causing visual field defects, and there is no evidence of raised ICP or life-threatening mass. What's the treatment of choice of this condition? So they are saying mostly NF associated with NF1 associated uh, this tumors. Okay, so optic nerve glioma is the main thing. Chemotherapy should be the answer. Just see. So what book says? Okay, in this asymptomatic children, we have to do MRI, but all asymptomatic children undergo MRI screening and other selitunimab, which is oral inhibitor of mitogen activity protein kinase, and has been approved after age of 2 years. So basically, symptomatic is treated with chemotherapy. Asymptomatic we need not to treat. Okay. So, question number 88. A 22-year-old man presents with gradually progressive pill-rolling tremor at the wrist, bradykinesia, shuffling gait, mass facie, and depressive symptoms. He is diagnosed with Parkinsonism disease, which is known to occur due to degeneration of dopaminergic neuron in nigrostriatal pathway. I don't know exact stem of the question was it like that, but crux of this question will remain same. So this is hypothalamus, red nucleus, basal ganglia, and cerebral cortex. Answer should be basal ganglia. Okay, because Parkinsonism disease results from degeneration of dopaminergic neurons in substantia nigra pars compacta. Again, very much important. These neurons project to striatum, chordae plus putamen, which is part of basal ganglia. Again, very much important. Okay, ETCO2 graph was there, and they were asking about some marking like what is type B. So they have marked this structure. So ETCO2, we need to understand this. So I think they were asking about this in question. So just see, this is the timeline on x-axis and expired CO2 on y-axis. So just this, follow this. At the end of inspiration, CO2 traces should reach 0. So at the end of inspiration, the CO2 traces should reach 0. Okay. So in this, just see, this is transition part of curve. Okay, very much important. This represents mixing of dead space and alveolar space. Okay, alpha angle. This represents the changes from the alveolar gas to airway gas. Very much important. Alveolar part of curve. This represents plateau average alveolar CO2 concentration. And this is marking of end-tidal CO2. This represents the maximum areolar CO2 concentration. So this graph was asked, and this was the original question. You need to remember all parameters, all things around this actually ETCO2 graph, because next question expected out of it. Okay, next, question 92. A researcher want to study association between two categorical variables, each having two possible outcomes, yes or no, such as exposure, yes or no, disease, yes or no, in two independent groups. Which of the following test is most appropriate for his analysis? Options are unpaired t-test, ANOVA test, chi-square test, Pearland coefficient. Answer should be C. Okay. So, I have just compiled the simpler version of this stats test or PSN test. So just stay attentive. Just look for data. Okay. So, chi-square is for use for data analysis. If number is small, Fisher exact test is used. If before or after is seen, it is McNamara test. Okay, if their numbers are there, two groups are there. If they are same person, it is paired t-test, and if they are different person, they are unpaired t-test. And more than two groups, it is ANOVA. Okay, relationship is not comparison, correlation, normal with Pearson, not normal with Spearman. Again, very much important. Okay, so this was it for today's discussion. Okay, so this is part 3 of NEET SS Recall. I hope you liked Recall, and this helped in your preparation of upcoming exam, because upcoming exam in 2026 is not far. It can occur after 3 to 4 or 5 to 6 months at the max. Okay, so revise this section of lecture again and again, and we will meet in another video to complete our discussion of NEET SS Pediatric Recall. Till then, stay blessed, and having a good time is mandatory for all of you. Okay, so we will meet in next another video.